Today we're diving into a major review from JAMA that breaks down the evidence-based medical treatments for opioid use disorder, or OUD. We're going to look at the pharmacology and the real-world clinical use of medications that are, without a doubt, proven to save lives. So let's get right into it.
Here's how we're going to tackle this. First, we'll get a sense of the scale of the crisis. Then, we'll explore the science of what's happening in the brain with addiction. After that, we'll review the powerful evidence for treatment, compare the different clinical options, and cover how to manage withdrawal and overdose. We'll wrap it all up with the key take-home messages for clinical practice.
Okay, so first things first. To really understand why these treatments are so vital, we have to grasp the sheer scale of the opioid crisis.
And, the numbers here, they're pretty staggering. An estimated 3.7% of adults in the U.S., that's more than 9 million people, have OUD. In 2024, it led to almost 54,000 deaths. And get this, fentanyl was involved in 88% of them. But the most critical part of this slide, in my opinion, is the treatment gap you see on the right. Only about a quarter of people with OUD actually receive medication-based treatment. That gap, that's a massive opportunity to save lives.
Now, to really get why these treatments work, you first have to understand the disease itself. And this is key. Opioid use disorder is a chronic, relapsing brain disorder. It is not a moral failing.
So what exactly is happening inside the brain? This slide does a great job of showing the cycle of addiction. When someone repeatedly uses opioids, it throws the brain's own natural opioid system out of whack. This leads to some really profound changes, especially in a part of the brain called the locus coeruleus. And that drives this vicious repeating cycle of binging, withdrawal, and preoccupation. This is the biological engine of addiction, and it's exactly what these medications are designed to interrupt.
All right, so now that we have a handle on the brain science, let's get to the evidence. Just how effective are these medications?
Look, if there's one thing you take away from all of this, let it be this. MOU saves lives, period. And we're not just talking about reducing drug use. We're talking about preventing death from all causes in this patient population.
And this slide just shows you the incredible power of that effect. The data is crystal clear. For patients in treatment, methadone is linked to a 50% reduction in all-cause mortality, and buprenorphine, an even greater 60% reduction. I mean, these are just unbelievably powerful, life-saving interventions.
But here's the catch. To get that huge mortality benefit, patients have to actually stay in treatment. That's what this slide is all about. You see, retention is a key predictor of survival. At the 1-year mark, retention rates for methadone and buprenorphine are pretty similar. Both keep nearly half of patients engaged in care. And that sustained treatment is what ultimately translates into lives saved.
So, we know they work. Now let's get into the specifics and compare the 3 FDA-approved medications that make up our MOUD toolkit.
Let's start with methadone. The big thing to know about it is that it's a full mu opioid receptor agonist. So what does that actually mean? It means it activates the same receptors as other opioids. And that gives it a huge clinical advantage. You can start it immediately, even in a patient who is actively using, without causing something called precipitated withdrawal. That's a huge deal.
But, and this is a big but, methadone's pharmacology is really complex. You can have a shocking 17-fold difference in blood levels between 2 patients on the exact same dose. It's broken down by an enzyme called CYP3A4, which means other drugs can interfere. For example, an inducer like rifampin can speed up its breakdown, and suddenly your patient is in withdrawal. On the flip side, an inhibitor like fluconazole can slow it down, raising levels and risking sedation or even overdose. So you can see why this requires really careful, individualized dosing.
So how do we manage this in the clinic? Well, we need specific protocols. For instance, with fentanyl being so potent, we often need higher starting doses of methadone, sometimes up to 50 milligrams. The goal is to get to a maintenance dose of over 80 milligrams a day for it to be effective. We also have to keep an eye on cardiac safety because methadone can prolong something called the QTC interval, which is just a measure of the heart's electrical rhythm. But while ECG monitoring is important, let me be clear, not being able to get one should never, ever delay starting this life-saving treatment.
Next up is buprenorphine. As a partial agonist, it has a fantastic built-in safety feature, a ceiling effect on respiratory depression. But, and this is its central challenge, it binds to that opioid receptor like superglue. Because of that high affinity, if you give it too soon, it will literally kick all the other opioids off the receptors and trigger a really severe precipitated withdrawal. That's why the standard way to start it requires waiting for the patient to already be in mild to moderate withdrawal.
And that brings us to our third option, naltrexone. Now, this one's different. It's an antagonist, which means it completely blocks the effects of opioids. No euphoria, nothing. And while the long-acting injectable form works well once a patient is on it, there's a huge hurdle to getting started. A patient has to be completely opioid-free for 7 to 10 days before the first dose, and for many people, that's a really significant barrier.
So when you lay it all out, how do you actually choose a medication? Well, as this slide summarizes really nicely, it all comes down to shared decision-making. You have to consider patient preference, logistical things like travel time to a clinic, and other clinical factors. But the biggest difference, really, is that extended period of abstinence you need before starting naltrexone.
Okay, so we've covered the main medications, but we can't stop there. We have to talk about two other absolutely critical parts of care: managing acute withdrawal and reversing an overdose.
All right, this is a really important point. We have to debunk the detox myth. Just managing a patient's withdrawal symptoms and then sending them on their way is not just ineffective, it's dangerous. It actually increases the risk of dying because their tolerance drops, making a relapse much more likely to be fatal. The standard of care is always to bridge patients from withdrawal management directly onto long-term MOUD.
And what about reversing an overdose with naloxone? Here's the key. The goal isn't to wake the person up completely. The goal is simply to get them breathing again, ideally above 10 breaths per minute. If you give too much, you can throw them into a severe, precipitated withdrawal. So remember the phrase, titrate to breathing, not consciousness.
And this slide just brings it all together beautifully. Untreated opioid use leads to withdrawal. But withdrawal management isn't the final destination. It's just a bridge to the real goal, long-term remission with MOUD. And that sustained retention is what's proven to lead to better outcomes, and most importantly, lower mortality.
All right, we have covered a ton of ground. So let's boil it all down to the key take-home messages that you can actually use in clinical practice.
Let's wrap this up with 4 essential takeaways. First, and most importantly, MOUD saves lives. It reduces all-cause mortality by up to 60%. Second, methadone is a fantastic tool, but its complex pharmacology means you have to be careful and individualize the dosing. Third, withdrawal management by itself is not a treatment. It's a bridge to nowhere if you don't connect patients to long-term MOUD. And finally, with naloxone, remember the goal is to restore breathing, not consciousness. Applying these evidence-based principles is how we can effectively fight the opioid crisis and, quite simply, keep our patients alive.